Somebody just joined. Okay. All right. I'm going to open it up. Okay.
Sounds good.
Great.
Welcome everyone to our webinar series part 2. We'll be starting in about 2 minutes from now, just waiting for a few other people to join.
Welcome, everyone. Thanks for joining us. We'll get started in just a minute.
Okay, so we're just gonna I'm just gonna start. So welcome again. I'm Cameron McIntosh. I'm here with my colleague Claire. And I'm just going to start off by setting the agenda for the webinar. So next slide, please. So for today's webinar, we will be doing an overview of part 1. And there will be presenter introductions, some housekeeping, and then the presentation. Next slide, please. So the New York City's Health Department's youth suicide prevention initiatives are being executed through interdisciplinary partnerships with community-based organizations, researchers, designers, and medical institutions across New York City, or BIPOC youth suicide prevention pilots and services, include innovative suicide prevention pilots that serve youth and young adults of color. We have our Caring Transitions, which is a collaboration between NYC's Department of Health, Health and Hospitals, and the Mayor's Office of Equity, which is to reduce suicide-related readmissions to emergency departments for youth in Queens and the Bronx ages 5 to 17 years old. Next slide, please. So the Department of Health is also investing in action-oriented research and capacity building efforts intended to raise awareness about suicide risk and prevention factors for New York City's BIPOC youth. This is why we are hosting a series of 4 webinars over the next several months dedicated to this topic. And so as a part of that, we will be providing enhanced monitoring of suicide as an urgent public health issue. We will increase and diversify suicide prevention services for youth and their support networks. We will expand efforts to mitigate the socio-environmental risk factors for suicide through interdisciplinary strategies. Next slide, please. just providing an overview of the first webinar that we did, which was hosted by Dr. Erica Bath, and Dr. Bath discussed trends in suicide among BIPOC youth through an intersectional lens, and she also covered systemic racism. Next slide, please. And now I will pass it to my colleague, Claire, to introduce our speakers today. Thank you.
Thanks, Kamar. My name is Claire Ogburn, and I'm the Data and Program Coordinator for Suicide Prevention Initiatives at the New York City Department of Health and Mental Hygiene. And I'll start by introducing today's speakers. First, we have Dr. Jocelyn Meza. She's a bilingual clinical psychologist. Dr. Meza is Assistant Professor in Residence in the Department of Psychiatry and Biobehavioral Sciences at UCLA. And she is the Associate Director of the Youth Stress and Mood Program and the Principal Investigator of the Health Equity and Access Research and Treatment Lab, also at UCLA. Her research and work aim to integrate psychological, cognitive, and sociocultural influences to predict suicide and self-harm behaviors and to identify therapeutic targets for culturally responsive interventions for youth of color. Thank you for joining us today, Dr. Meza. Next slide, please. Our second presenter is Dr. Aaron Godfrey. Dr. Godfrey is Associate Professor of Applied Psychology at New York University and Director of NYU's Institute of Human Development and Social Change. Her scholarship integrates perspectives across multiple disciplines to examine the psychological processes that underlie people's responses to systemic oppression, to address the individual and societal consequences of these responses, and to unpack the ways in which systemic oppression can be disrupted in systems and settings. Thank you for joining us, Dr. Godfrey. And next slide. Our third speaker today is Dr. Shabnam Javdani. Dr. Javdani is Associate Professor of Applied Psychology at New York University, and she directs the NYU Prison Education Program, which expands access to higher education among incarcerated students. Dr. Javdani's scholarship examines and disrupts the impacts of social inequity through community, policy, and systems solutions that promote mental health, resource access, and social determination for historically disenfranchised groups. And Dr. Javdani's work examines mass incarceration, juvenile legal and child welfare policy, persistent poverty, housing instability, and educational pushout. So thank you for joining us today, Dr. Javdani. Next slide, please. Finally, I'll go over some housekeeping items before we get started. So as Kamar stated, this is part 2 of a 4-part webinar series. We're recording all of the webinars and we're working on the best way to get you the recordings now. So if you've missed part 1 or you can't attend parts 3 and 4, you'll be able to watch them later. Secondly, our presenters have done their best to use sensitive language in this presentation, but the topic could be triggering. So we will share resources about 988, the Suicide and Crisis Hotline, with you in the chat and via email after the webinar. And there's also there's a QR code on this slide that you can scan with your phone. The chat is open and we welcome your comments and reflections there. But if you have questions for the presenters, it would be best if you use the Q&A function to send in your questions, and we'll do our best to answer your questions, all of your questions after the presentation. Lastly, we'll be sending out a quick survey at the end of the presentation for you to share your thoughts with us, and we really hope you'll fill it out so that we can take your feedback into account for parts 3 and 4. And that's it for housekeeping. So I'm going to turn it over to Dr. Meza and she will begin the presentation.
All righty, can everyone see my slides? They're up and running.
Yes, we can see.
Okay, perfect. I was going to say good morning because I'm in California, but good afternoon for all of for everyone that's in the East Coast. I am excited to be here today to continue the conversation that Dr. Bath already started a few weeks ago, and she really set the stage on how structural settings impact suicide and suicide risk. And today I'm going to delve more into what are the social cultural risk and protective factors that interact with structural settings to predict suicide risk for ethno-racially minoritized youth. Since time is limited for today's conversation and presentation, we are going to be highlighting or focusing on Black and Latina youth. Okay. There we go. I do want to first share some financial disclosures. So these are some of the funding resources that I have received to conduct some of the research that I'm going to be sharing today. And all slides will be available to everyone that participated today. So we will be sharing them after today's webinar. But I do want to share that the opinions in this presentation are opinions of myself as a clinician and professor, and not necessarily of those at UCLA David Geffen School of Medicine. It's a required disclaimer that we have to share. And you're free to use these slides for your own learning and fair use purposes, which means you can use them for teaching purposes or for whatever you'd like. Thank you, Claire, for also giving a trigger warning. I would be remiss if I didn't do the trigger warning again. As a clinician that treats suicide on a daily basis, I have to remind myself that this is a very sensitive topic that we discuss with everyone. So if you need to take a mental health break, feel free to do so, to step away, grab some tea, and know that the resource 988 is available. And if you need more additional resources, please reach out to myself or to one of the presenters. We will share our emails on the chat so that you can reach out if you would like to have more resources for suicide prevention. Okay, so to give you an idea of what we will be discussing today, I'm going to spend some time talking about disparities and current surveillance data and how that has captured our current public health crisis. I'm going to spend most of the time talking about social cultural risk and protective factors and how those have impacted suicide risk. And then I'm going to end up in a more positive note and talking about what are some possible solutions to make suicide prevention more equitable. So first, I want to start with terminology. In the previous discussions and in the webinars that are coming up, we use the term SITB. So what does SITB mean? SITB is really an umbrella term that stands for self-injurious thoughts and behaviors. So this is a very broad umbrella term that captures two broad level behaviors. So one, it's suicidal behaviors. So these include a suicide attempt. So this is any bodily harm or anything done to oneself with the purpose of ending one's life, a suicide plan, and then suicide ideation. Within suicide ideation, which encompasses having thoughts of suicide, there really is a really wide range of suicide ideation. So I'll give you an example of passive suicide ideation, which we tend to hear more in younger children. These are thoughts of death, right? So it could be wishful thinking, wishing you would not wake up one day. So those are more passive. More active thoughts of suicide are things like, I wish that I were dead, or I wish that I could die. So they really are on a spectrum of severity. But all of the ones that I mentioned on the left side, all of these thoughts and behaviors are with the intent to die. If we move a little bit further to the right on what we tend to understand as less severe, we have those that are non-suicidal. And the most common form of non-suicidal behaviors and thoughts is something that we refer to as non-suicidal self-injury, NSSI. So what are some examples of NSSI? These are things like cutting or burning of the skin. And again, they're different methods and they're on a pretty wide range of severity. One term that I really hope that we eradicate from our lexicon and from our use is the word suicide threat or suicide gesture, which is really any behavior that a person can do to indicate that they're in distress. But there's some, stigma or negative connotation with the term a suicide gesture. It really diminishes how severe it could be. So along those lines, I want to spend some time to talk about what are the appropriate terms or language that we should be using when we talk about suicide. Part of suicide prevention is for us to use language that destigmatizes this. And as a clinician, I have heard a lot of these terms used freely, and I use that as an opportunity to really talk about what are some more appropriate terms. So the most common one that I hear that I hope people will start changing as part of their language is the term someone committed suicide. This really has the connotation of criminal behavior, where we're really criminalizing self-harm or suicide. So instead of this term, I would encourage you all to use the word someone died by suicide. The same thing with a successful or a failed attempt. I have heard so many doctors in the emergency room refer to successful versus unsuccessful attempt. This is not something that we want to attribute success to, right? So a more appropriate term for this would be someone died by suicide or someone had a suicide death or a survivor of an attempt. The same thing with suicide ideator or attempter. The most common term that I've heard is someone is suicidal. It is not a personality trait. It is not something that is fixed. It's something that changes from time to time. So one thing that I would encourage you all to use instead of someone is suicidal is to say it's a person that has thoughts of suicide or someone that has had a suicide attempt. Another one that I just mentioned that I want to eradicate from our language is suicidal gesture, or when parents refer to this as manipulative behavior. That can carry a lot of stigma, especially for adolescents. So a more helpful way is if we just describe the behavior and what it was. And then the last one is dealing, like if it's a negative problem that we have to deal with, dealing with suicidal crisis. More appropriate term for this would be working with someone in crisis. Dr. Javdani, is there anything else that you would want to add to this? I know there's a long list, but these are the most common ones that I hear in my clinical practice as I'm working with families and with other clinicians. Is there any other one that you would want to add?
No, Dr. Mesa, that was a beautiful way to cover and to the terms and to remind us that suicide is a public health issue and not an act that is disruptive or something that should be considered criminal, as you said. Thank you.
Okay. Thank you. So now I want to point everyone to really understand what is really this public health crisis that we're encountering. So these are the 10 leading causes of death in the US by 2020 from the Centers of Disease Control. And as you can see, suicide is either the second or third leading cause of death for children and adolescents ages 10 to 24. So this is really alarming since these have only gone up in the last years. And for the first time ever, suicide is in the top 10 for young children 5 to 9. So I always like to show this graph because it really helps us understand the urgency of this issue. What you're not able to see from this graph, and the numbers underneath the word suicide are the records, the death records that were documented within that age group. What this fails to do is it fails us to give us a snapshot of what really is going on with the youth in our country. So I always like to cite the Youth Risk Behavior Survey, which is a national survey of high school students across the US. And it gives us a better sense from an epidemiological point of view, what are the current rates across these different cities. So in a given year, 22% of high school students have seriously considered suicide. So this went up about 3% from 2019 pre-pandemic, and it keeps going up each year. 18% of high school students in the last 12 months or in a given year have made a plan for a suicide attempt. 10%, so 1 in every 10 high school students across the US have made a suicide attempt. Out of those 10%, 3 have been significantly injured that they had to, seek care in an emergency department. So this gives us an even closer picture of what this public health crisis really is. And the reason why I highlight these risk behaviors is because these are the strongest predictors of future attempts and of future death by suicide. So these are the things that we want to target as a preventative measure, right? I know that we briefly touched on these in the previous webinar, but I do want to show the differences by race ethnicity, because what this graph does is it gives you the overall picture, but it doesn't tell you who is in distress, who is suffering. So I always like to break down the data by different social demographics. Again, this is just a quick snapshot, but what you can see here is that girls in particular are reporting higher rates of thoughts of suicide. And if we look within race ethnicity, they're pretty elevated across the board, but primarily for American Indian and Alaska Native, they're at 27%, and multiracial youth. So these are for 2021. If we look at trends of thoughts of suicide in the last 10 years, you can see here that for females or for girls, this trend, there's an upward trend across all years. This is a trend that we see by race ethnicity for some groups. So if there's a yellow square, it means that it's not improving, but it's not getting worse. If it's red, it means that it's going up, it's getting worse. And as you can see for Black, Hispanic, and white children, these rates are going in the opposite direction and they're going up. So if you, for example, look at Black youth, they started at 13% in 2011. Fast forward 10 years, they're currently at 22%. So this gives you an idea of trends across time. We see a very similar pattern for suicide attempts, where, again, girls have almost double the rate. And if you look across race ethnicity, this is where we start to see the disparities across race ethnicity. For suicide ideation, more or less, they're around the 20th percent, but we really start to see the disparities to really widen once we start looking at attempts. So here you can see that Black youth and American Indian and Alaska Native youth have the highest percentages for suicide attempts, which I already mentioned are the strongest predictors of death by suicide. And if you also look at sexual gender minority, they're exponentially at higher risk. The trends look very similar for ideation. So for attempts for females, again, an upward trend. And if we look at race ethnicity, we see that for Black youth in particular, trends are going up. And one thing that the Youth Risk Behavior Survey fails to do is to look at data from an intersectional point. So I always have to create my own table to be able to calculate the differences by race, ethnicity, and gender. And the point that I want to highlight from this table here is that the disparities by race ethnicity get even larger when we add another identifier, in this case, gender or sex assigned at birth. And you can see that for Black females, rates of suicide attempts are at 17.8%. So nearly 18% of Black girls are reporting that they've had an attempt in the last year, compared to 13.8% for Latinx or Hispanic girls. And we see a very similar pattern for Black boys, and where they're at 11.2%. So nearly double from non-Hispanic white youth. And really what my work has tried to uncover or understand is what is leading to this disparity. Why have we been documenting these disparities since the 80s? and yet they continue to go in the opposite direction. What are we not doing right? And what do we need to do to disrupt these disparities so that we don't continue to lose the lives of so many Black and brown children? So how do you really implement and scale up suicide interventions in the community? The very first step is to collect data to understand the problem. And currently, we do have some pretty good surveillance data, like the Youth Risk Behavior Survey. However, our surveillance data fails to capture the kids that are most marginalized and that are most at risk. And in a few slides, I'm going to talk about who those kids are. But I want to point you to step number 2 in developing public health models of suicide. Step 2 is to really identify risk and protective factors. The issue with this is that in the last 50 years, all of our examination of risk and protective factors have primarily looked at the individual level. So what do I mean by that? We already know that depression is linked to suicide. We know that anxiety, ADHD, and conduct disorder, we know that those individual level factors are associated with suicide. What we don't know is how structural, sociocultural things impact risk of suicide. And that's what I'm going to spend the next 20 minutes talking about, is how these broad level, multi-domain risk and protective factors impact suicide, because that is what is going to guide our equity-based interventions. So again, in more lay terms, suicide prevention or interventions, what they really aim to do is 2 things at the same time. They aim to reduce risk factors while at the same time promoting or enhancing protective processes. And I'm going to highlight what are some risk and protective factors that we have found in more structurally marginalized communities. So if we look at the individual level, there has been some new and interesting research that has found that lower levels of ethnic identity attachments actually increase risk for suicide. So what does that mean? Having a strong ethnic identity attachment means that you feel that you belong and that you have a connection to your racial ethnic identity. In my example, for me, I am very strongly attached and I strongly identify with being Mexican. Sorry, someone had, there we go. And this is exactly what this study found in a sample of college Hispanic students. What they found was that those students that really didn't identify with their ethnic identity, they felt more that they didn't belong, they felt that they were a burden to society, and then that mediated the risk for suicide. Other factors how am I on time? Okay, I'm gonna skip over this, but if we have time, I do wanna come back to talk about identities and how they impact not just risk for suicide, but at the individual level as clinicians, it impacts how we treat our patients. So if there's time, I'll come back to this in a few moments. Other factors at the individual level that have been shown to increase risk for suicide are things like generational status. So this is what we refer to as the immigrant paradox or the Latino paradox, that highlights that if you're a first generation student or first gen, that you're somehow protected from mental health outcomes, and there's different interpretations as to why. And then if you look at immigration histories, there has been studies that look at specific acculturative stress and how that has increased the number of suicide attempts, in particular among women. And some newer research that we have done when we look at adolescents and their parents, and when there's cultural differences in their values, what we're finding is that the larger the acculturation gap between parents and their teens, the higher the risk for suicide. One possible reason why this might be is because larger acculturation gaps lead to more conflicts in the home, which we already know is a strong indicator of risk for suicide. So these, again, are all at the individual level, but looking within culture. And that was just an example of one. But if we span out to the family or peer level, we can see that family and parents really make a huge, they really do increase risk for suicide. And one particular study that I like to talk about is parental incarceration. In several studies with adolescents and with children, we have consistently found that there's something about parental incarceration that is associated with higher odds of suicide ideation and attempts. Some of the potential reasons that may be explaining this link is that if parents are incarcerated, they're not monitoring their kids. So there's higher risk for them to engage in riskier behaviors. Incongruence in academic aspirations between parents and kids have also impacted risk for suicide. And in one study that we did with about 400 Mexican descent college students across the US, what we did is we surveyed these students and we asked them about conflict with their parents, but conflict that stemmed from cultural differences. And what we found was that intergeneration acculturation conflict moderated the link between depression severity and probability of suicide attempts. So what that means is that depression in itself, it predicted risk of suicide, but when you added the intergenerational acculturation conflict piece, that really increased the probability, or what we call the risk, of suicide attempts. So there's something unique about cultural differences with your caregiver that were really impactful in the relationship and in the risk of suicide. If we expand a little bit broader to the social or community level, and Dr. Bath already alluded to this in the previous webinar, we're finding that experiences of discrimination, even if they're subtle forms of discrimination, which we refer to as daily microaggressions, among Black and Latinx adolescents, increase their feelings of feeling that they don't belong in the world, that they're not important, and then that led to suicide ideation. In a large meta-analysis, what they found was that experience of discrimination seemed to have a particular or stronger effect on girls versus boys. So it would be interesting to try to understand what really about girls is leading to this differential effect. And exposure to community violence has also led to more feelings of acquired capability for suicide. So acquired capability for suicide is one of the factors in the interpersonal theory of suicide. And what this construct gets at is at your ability or your thinking that you can actually go through with your plan. So if you have acquired capability for suicide, that means that you really have the belief that you are capable and able to go through with the plan. And in more recent studies during the COVID pandemic, we did a survey of Latino college students across the US, and we assessed for their attempts during the COVID pandemic. And what we found was that their experiences of racial bias in media, so not just on TV, but in social media, feeling that their group or their racial ethnic group was negatively portrayed in social media or in media outlets, that led to more perceived stress, which impacted their total depression symptoms, and then that led or predicted their suicide attempts. So here what you can see is what we call an indirect pathway of racial bias impacting suicide attempt through perceived stress and total depression. Now, I really don't want to lead the conversation from a deficit perspective and just focusing on risk factors. There's actually a lot of protective processes or cultural assets that are protective in the case of suicide. So what are some of those factors? At the individual level, we see that students and adolescents, especially during identity formation developmental periods, which tends to happen in that transition from adolescence to young adulthood, higher effective ethnic identity reduces your risk for suicide attempt, meaning that if you strongly connect and identify with your ethnic background, that is associated with reduced risk of suicide. Now, I want you to think, if you do provide care for suicide, is this something that you have integrated into your care if you work with Latino or Hispanic students? And ask yourself why or why not, what's getting in the way of you adding these components into your treatment. The second one is that odds of death by suicide are significantly reduced by 6 times if you have an affiliation or a connection to a religious community. This has also been replicated in samples of Black adolescents. So there's something protective about religiosity in the context of protective factors. I do want to note that religious affiliation is not always a protective factor. It's actually been shown that for sexual gender minority students of color actually has the opposite effect. So it has some protective value or factors in certain demographics, not in all. If we expand to the family and peer level, we see that tight-knit families have lower incidence of suicide. And what I mean by tight-knit families, these are families that have low conflict, but high communication and high warmth. If you have an adult that believes in you, it doesn't have to be a family member, just any mentor in your life, especially for Latino girls, that has shown to be a protective factor. And in Latino culture, we talk a lot about familism, which is a cultural value that really centers the importance of family as a cultural value. And I put an asterisk next to this construct because in some studies, familismo or cultural values around family have been protective for suicide among teens. And in some studies, it actually has increased risk. It just depends on the context. And if we expand again, and this is my favorite slide, to the community or social level, protective level factors, we see that political activism serves as a protective factor to mitigate the effect of discrimination on stress and depressive symptoms among Black and Latinx students. So we see here that civic engagement is a way of resistance and a way of coping with their experiences of discrimination on and off campus. So one thing that I've started to integrate in my practice when I see adolescents or young adults, I ask them, what are some ways that you can fight back and you can fight for social justice? And then we talk about how they can be involved in the community, either through political activism or civic engagement. Another one at the community level that I think it's important for people that are in a leadership role is that cultural diversity and inclusion reminders have reduced stress responses for Latino students on campus. So what do I mean by cultural diversity and inclusion reminders? These are things that you can put on your wall to indicate that you value justice, equity, and inclusion. So think about the space that you provide for your clients, for your students, for your trainees. Is your environment sending that message or that reminder of inclusion and diversity? And how can you make your space more promotive of that? Okay, and then this, I'm not gonna go through it, but I like to include in my slides, it's just a summary of all of the social cultural risk and protective factors for Latinx and Black youth that I'm going to include in your slides as a summary slide. And I want to now pivot to talking about a group that has been historically A, underrepresented in suicide research, and B, historically underrepresented in our surveillance data. So if you remember a few slides back, I talked about how step number one in the public health model for suicide prevention is to collect surveillance data that captures the problem. The problem with the the Youth Risk Behavior Survey is that it collects data among high school students that are enrolled in high school and that actually show up to high school. One group that is historically impacted by suicide and that doesn't include that, is not part of that data collection, are youth that are in the juvenile legal system or youth that are impacted by the child welfare system. So the data that I showed you doesn't capture these groups that are at exponentially higher risk for suicide. In fact, suicide is the leading cause of death for youth that are impacted in the juvenile legal system. And you remember from a few slides back, I had that suicide was either the second or third leading cause of death for youth in the general population, but for youth that are impacted by the juvenile legal system, this is their leading cause of death. And one of the main issues with, or that's impacting suicide risk among youth that are in the juvenile legal system is that they tend to be what we call dually involved children or crossover youth. These are youth that are impacted by two oppressive symptoms, the child welfare and the juvenile legal system. And this really potentiates their risk for suicide. So most youth that are part of the child welfare, more than 50% are referred to juvenile court for delinquency. So there's a huge overlap between these two systems. And then youth with dual jurisdiction, both child welfare and juvenile legal, make up 1% of informal diversion cases. That's a problem. That means that these kids are not being diverted into the care that they need. 1%, I don't know if that's just alarming to me, but that is a pretty low number. We would want to see that to be a higher number. And what the literature has suggested is that children that are in foster care or that in care settings, their risk for suicide attempts is 3 times higher compared to youth that are not in care facilities or part of the child welfare system. And there's different types of placements, but just in general, being in placement increased risk by a 3-fold. And if we look at their specific rates of suicide ideation and behavior for youth that are detained in juvenile settings, we see that 70% of youth that are in detention settings have a history of suicidal behavior or a previous attempt. 46% of children that are incarcerated report a previous suicide attempt, and 31% predict or 31% report or endorse suicide ideation. And one thing that I want you all to think about here is, why is it the rates of suicide attempts are actually higher than the rates of suicide ideation? In the general population, it's actually the reverse. We see that ideation tends to be significantly higher, sometimes double, than attempts. So why is it that we see the reverse for youth that are in the juvenile legal system? So if you have some ideas as to why we're seeing this reverse effect, put in the chat what you think may be leading to this effect. So what are some of the risk factors that are impacting risk for suicide among children that are in the juvenile legal system? The leading factor that impacts their risk for suicidality is childhood trauma. So, and I guarantee is higher, but about 90% of detained youth report previous childhood trauma, mostly sexual abuse, physical abuse, and neglect from their caregivers. And for girls in the juvenile legal system, sexual abuse actually tends to be one of the leading causes of suicide by death, death by suicide, I'm sorry, and their number of attempts. And then 2 other factors that have emerged more recently as impacting the risk is homelessness and running away from home. And if you think about these 2 risk factors, homelessness and running away from home both of these remove the child from a protective environment, from a protective adult that can help them get into care. So the children that experience the lowest access to any type of treatment are kids that experience homelessness or if they have run away from home. In a recent study that we conducted in my lab, we looked at what were the main risk factors leading to suicide attempts among a group of girls with commercial sexual exploitation. And we found that ADHD, conduct problems, and ODD were the main predictor. The problem with this is that these externalizing behaviors, there's a lot of biases in the diagnosis of ADHD and conduct problem among Black and Latino youth. And B, there's probably some underlying trauma that can better explicate what the symptoms that we're seeing or the behaviors that we're seeing. So a lot of youth are getting misdiagnosed with these diagnoses of ADHD and conduct problems and not getting into the appropriate care that they need, the trauma-informed care that they need to reduce their risk. And I actually want to point, I always like to leave on a positive note. So I know I've been talking about risk factors for suicide among youth in the juvenile legal system, but I also want to talk about some protective factors that we found in our own study. And what we found was that having good communication or positive communication with a caregiver in your life, it doesn't have to be biological parents, it's just having a caregiver in your life, having good communication with them, having high self-esteem, and having family support, all of these three factors significantly reduced the risk for self-harm among children that were involved in the court for the very first time. So how do we enhance these protective factors in the treatment that we provide? How do we improve communication with caregivers? How do we improve an adolescent's sense of family support? These are all the things that I want you to keep in mind for webinar 4, when we will talk about culturally responsive treatments for suicide. So I want to wrap up in the last 12 minutes that I have here on some solutions that we can implement to make suicide prevention more equitable for youth in the juvenile legal system. The most upstream preventative effort is to abolish the juvenile legal system. While we keep working and advocating for this, there are some other things that we can do across the sequential intercept model. So the sequential intercept model really highlights the different intercepts at which we can defer a child into appropriate care or mental health services. And you can see that there's different intercepts that allow us for diversion. And I'm going to talk about some specific strategies across these different intercepts. And the intercepts are very important for suicide because what we have found in our research is that the further in that you go into the intercept, the higher your risk for suicide and the higher your risk of recidivism. So it looks like they move in tandem, and we want to disrupt some of these further penetration into the sequential intercept model because we know it increases risk for suicide. So this is a summary of all the points that I'm going to talk about. Again, I like having summary slides for everyone to consolidate the information, but I'm actually going to go through each intercept one by one. At intercept 0, which is the furthest, most preventative intercept in the sequential intercept model, is prevention. So these are things like primary care settings and school settings. Some strategies that we can implement is implement anti-racist organizational and policy changes. An example of this would be anti-racist policies within schools, and where Black and brown children tend to get criminalized for behavior that other children don't get criminalized for. Screen for potentially traumatic events and connect families to appropriate resources. Our school system is one of the, I think, the the best systems that can help us screen for these traumatic events because they see so many children and families are actually more likely to connect to resources if they're being connected from school as opposed to primary care. Another equitable solution is to address racism and discrimination related to trauma for ethno-racially minoritized youth. Some work that's being developed around this is developing interventions for school settings for children to learn how to resist and cope with racism. And this should be part of the curriculum that's implemented across settings and in schools. So there's some very interesting work done by some professors over at Stanford, and I can share some of those readings on these new interventions that are being rolled out in school settings. If we move to intercept number 1, which involves law enforcement, one very important issue that we need to address is to develop suicide risk protocols that are mandatory and implemented systematically throughout states. So there's differences across states on how law enforcement handles suicide crisis. And more importantly, research has shown that law enforcement or police officers don't feel that they're adequately trained to reduce a crisis. So we need to provide training in a trauma-informed way for all first responders or mobile crisis team, and to really target racial bias and anti-racist training. Another important factor at this intercept is to really de-police or to decriminalize crisis responses to suicide. The new development of the suicide hotline 988, which was implemented, I believe, July 15 of 2022. So it's been running for about a year. That was one possible strategy to decriminalize police being sent to home for a mental health issue. There's actually been some analyses of how many 988 calls have resulted in a law enforcement being involved. And the data are pointing to a very small number. About 2% of 988 calls have resulted in law enforcement being involved. Intercept number 2, which is the court setting, which is where Dr. Bath and I are embedded in. Court settings are very fast-paced. There isn't always a secure place for clinicians or mental health providers to be able to do screening for suicide. So one thing that I think would be really helpful is if there were private and safe spaces where youth can complete suicide screenings in court settings, not in a chaotic environment, because that leads to underreporting, especially if they feel that their risk assessment is going to impact court decision, and really educating the families on how suicide risk assessment doesn't impact their placements or court hearings. Training staff to provide equitable administrating and scoring and responding to the risk assessment tool. So training with all court staff on how to respond to crisis or how to do risk assessments. And then another important one is to develop and sustain active partnerships with community health agencies to ensure that there's timely response to referrals. This is one of the biggest issues that we see, is that we see that children are in need of mental health services, but wait lists in the community are really, really long. So how do we shorten that? How do we provide a better linkage to care for children that are involved in the court setting? If we look at intercept 3, which is already confinement or detention, the most important thing is to really implement trauma-informed suicide screening and risk assessment, coupled with brief and effective interventions. In California, right now, we're rolling out the dialectical behavior therapy within detention settings, developing and implementing more robust reporting guidelines that go beyond self-report. What do I mean by that? Children complete a risk assessment. More often than not is the MACI. So they already know what they're going to be asked. So they're more likely to not report ideation, even if they are experiencing it, because they fear that they're going to be put in solitary confinement due to their responses. It's also important that we prioritize research that examines the implementation of factors that are related to suicide. For a long time, a lot of researchers didn't want to do research on youth that are in the juvenile legal system because they said it's too hard to work in the system. It's too hard to recruit families into research. And I do think that we need to make a more concerted effort to work together with the juvenile legal system to do research that is going to better inform our interventions moving forward. The reentry period, so these are the first 6 months after a child has been in detention and is re-entering back into the community. This intercept has been shown to be the highest risk period in the juvenile legal system intercept because there isn't a warm handoff between juvenile detention centers and community mental health providers. A lot of times, parents and youth feel lost. They don't know how to connect into care. They don't know who to call. So they're really falling through the cracks and end up recidivating into the system. So we need to develop evidence-based interventions that have a key treatment component of linkage to care. The last intercept, community supervision, and this is my last slide. The gold standard for community-based suicide prevention is to do safety planning with lethal means restriction counseling. However, a lot of community settings are not implementing this. So at the most upstream level, we need to make sure that we're building capacity for our community workers on how to do lethal means restriction counseling as part of community supervision. We also need to have ongoing required screening of emergent suicidality throughout community supervision, not just when they're in detention or in confinement. And then develop, evaluate, and implement culturally and gender responsive interventions. I think that still needs a lot of work, but we're definitely heading in the right direction for the development of these interventions. Okay, now I want to get to the good part, which is to have a conversation and answer some of the questions that you have. So my email is on this slide if you have any follow-up questions. And while Dr. Javdani jumps on, I'm going to leave this slide for all of you to just give us feedback on what you would want us to integrate, if there's something that you would want us to follow up with. We're also going to put the Qualtrics link on the chat, or you can just scan the QR code and it'll take you immediately to the very brief 7-item multiple choice survey.
Thank you so much, Dr. Mehta. Thank you so much, everyone, for your responses in the chat so far. We have some questions that we are ready to provide for discussion as we also invite you to take this 2-minute survey. And as folks take the survey, please feel free to put any other questions that you might have using the Q&A function at the bottom of your screen, so that we can incorporate some of your thoughts and questions into the discussion portion of this. Great. We'll get started in just a second. One other opportunity for you all, if you would like to ask your question verbally, we are also happy to do that as well. You can use the Q&A function to indicate that, and then we will unmute you so that you can ask your question verbally if you like as well. Okay, great. All right. So Dr. Mehta, just as a thank you so much for pointing us to so many different ways to think about and understand suicide among system impacted youth, among youth of color, and to think about risk and protective factors at different levels beyond the individual young person, but also in their peer groups and the settings that they are in with their families and schools and so on. I want to start with the question that you asked of the group when you showed the slide that indicated that youth who were in the juvenile legal system had a higher sort of rate of suicide attempt and a lower rate of suicidal thoughts and ideation. And you asked folks to indicate what their thoughts were for why this was the case, given that it was the opposite in the population. Yes, exactly, this slide. So some answers that we got in the chat, some responses included things like lack of love and attention, that this was reversed potentially because of a lack of hope, and combined with an urgency to immediate action, factors related to immediate gratification, the invincibility fable, which might be more prevalent at this stage of life, and mental health, just the lack of access to mental health services. So we would love to invite you to respond to this and tell us your thoughts about this really alarmingly high rate of prior suicide attempt in relation to a slightly lower, but still, high rate of suicide ideation.
Yes. So there's two things that I would want to point out about this reversed effect. First is we have to think about who is disproportionately impacted or in the juvenile legal system. And we know that is primarily Black and brown boys and this Black and brown kids. That's one thing. Two, theories of suicide, for example, the suicide ideation to action theory proposes that before an attempt that there usually is a risk indicator, in this case, suicide ideation, that precedes the attempt. These theories were primarily developed with middle-class white children and families. So this theory of suicide ideation to action doesn't really apply to other children or adolescents, in this case, Black and brown children. What we're finding in our research is that this trajectory is not linear for Black and brown children. And also the ways that they're understanding their suicidality is very different. And I'll give you an example. Some of the ethno-racially minoritized kids that we see, when we ask, have you ever done something to end your life? Which is one of the screeners that we use, they say no. But I have gotten myself in harm's way. Like I started a fight with someone that I knew had a gun, or I started a fight with someone that I knew was a gang member and that they were gonna, gang up on me at the park. So there's this really interesting pattern of getting in harm's way as an indirect form of having a suicide attempt. So a lot of I think the point that I want to make is that the theories that we have had to date are not including, and they're not prioritizing the inclusion of Black and brown families into these research, so that some of the theories don't necessarily apply to these groups.
Absolutely. Yes, that's such an important point, and links to another kind of set of questions related to what you reminded us of, which is the really important fact that suicide is the leading cause of death among young people who are impacted by the juvenile legal and child welfare systems. And wondering whether you can further expand on some examples to help us understand what suicidal ideation, thoughts, and behaviors might be mistaken for when youth are in care. What are some signs that we might be missing when we're doing business as usual sort of in care, but also given what you just mentioned regarding the nonlinear trajectory between ideation and suicide attempt?
Yeah. I think some of the things that we may be missing are the nuances in which ideation and attempts manifest in certain groups, especially in younger children. Like the younger they are, the more difficult it is to do these risk assessment and screening. And if you look at example, the PHQ-9 item, it has one item that screens for suicide ideation and is used widely. Almost every hospital primary care system that I know of uses the PHQ-9. And the 9th item states, have you had thoughts that you would be better off dead? Or have you had thoughts of hurting yourself? And some of the families that I work with, and where family is so central to their being and their identity, they say, no, I don't think I would be better off dead. I don't think I would be better off if I were dead. I think my family would be better off if I were dead. So if we just switch one of the words in the PHQ-9 9th item and switch it from, do you think you would be better off dead, to do you think your family would be better off dead, they're more likely to screen positive. So we really need to think about manifestations of just stress in different groups, right? Are they engaging in more risky behavior, like starting fights, driving recklessly? Are they doing other things that to us may not appear as having suicidal intent, but for them it is, right? So I think just being more nuanced in the way that we assess, being more broad, right? And how we think about, suicide risk assessment. Oftentimes trauma is underlying a lot of these behaviors that I was mentioning.
Absolutely. So would it be fair to say that, especially for system impacted youth and youth of color, that a sense of being a burden on loved ones, which you alluded to earlier in your presentation, combined with risk taking with the knowledge that that risk can carry harm with it, that the combination of those things might not actually be an indication of recklessness, but might be an indication of distress. And that's a moment to think about suicide specifically.
Exactly. Yes, you said it so much better than I did. Your summary of it was perfect. Yes.
Yeah, and thinking about that, thinking about that combination, especially when young people might be, let's say, in residential care, in a treatment facility, a detention or placement setting. What are some things that you think that organizations, agencies, settings, providers can do in the short term that you have seen have really powerful effects? Maybe things that might feel or seem small in the face of these complex, challenging problems, but things that can be potentially done that might have a really powerful influence on addressing that sense of burden, or on supporting providers to feel agency and to feel equipped to respond in a way that is life enhancing for young people.
Yeah. So is your question here in me sharing what I think would help different clinics or spaces on how to be more thoughtful of the different manifestations, or are you more interested in provider level techniques?
I think both, absolutely both, could be
Okay.
very interesting to share.
Okay. One of the most powerful things that I have found that has been very beneficial, and I did a training with firefighters in California, is they really wanted to learn how to address bias in the workplace. And when I did I'm going to bring back the slide. I said I was going to come back to it, so I'm going to come back to it. We did this reflection on identity, and I talked about the continuum of cultural consciousness. So there's many steps to achieve what we all want to achieve is cultural safety. And at the most basic level, we have cultural awareness, one's ability to recognize that there's differences across cultures and groups. Cultural sensitivity is to have a non-judgmental stance when understanding differences between groups and cultures. Cultural humility is another step on that continuum of cultural consciousness, and is when you not only respect other people's differences, even if they may be different than your own cultural values, but it's also the self-reflection that you take on how your own identities impact and potentially bias you in your workplace and in the care that you provide. So I had a talk a few days ago, and where I had clinicians think about what are the identities that you think about the most often, and write them down. And if people in the chat, if you feel comfortable, share some of the things in the chat. What are the identities for you as a person that you think about the most often? And then I'll wait for some people to add into the chat. I also want to reflect on what are some of the identities that you feel have the strongest effect on how you perceive yourself as a clinician. Which identities do you bring into the clinical room or into your training if you are the director of a clinic? Which identities do you feel impact your leadership, impact your clinical practice, impact your research? And I want you to reflect on those identities. And part of cultural humility, which is not an endpoint, but a lifelong process, is to really evaluate how your own upbringing, your own experiences in the world, how your own identities might impact the care that you provide, and to do something to mitigate that, to mitigate those biases. That's cultural safety. Cultural humility is when you reflect on it and you're aware of it. Cultural safety is when you do something to remove the power balance that there is between you and the people that you're providing care for, by addressing those structural social biases that you may be having. So I think one of the things that I would recommend for providers or for clinic directors is to really have some time to reflect on how our own identities impact the services that we provide, how our physical, for example, how our clinic looks. Does our clinic have messages of inclusivity? Does it not? I think that's the most basic thing we can do, right? In order to get a step closer to really being more equitable in our approaches. And then I think the second one is just how we screen for suicide ideation, for suicide risk. We should be screening for discrimination. And this is something that Dr. Bath and I have been talking about for a long time, is how can we make screening for discrimination universal? And why am I talking about screening for discrimination in the context of suicide? You just brought up, right, how experiences feeling that you don't belong and that you're a burden to society, those are probably the strongest factors that lead to suicide attempt. But if we take a step back to see what is leading to those feelings that you're a burden to society, that you don't belong. For a lot of Black and Latino youth is experiences of discrimination, even if it's like vicarious discrimination. So if they see that their parents experience it, they themselves are experiencing it, those experiences of discrimination have such a robust and linear effect on feelings of burdensomeness and belongingness. So long story short, those would be my two, I think, basic recommendations, is to do an introspection on identities, and to also think about how you can screen for other structural things that impact risk for suicide, in this case, discrimination.
Thank you so much. Absolutely. Absolutely. And it sounds like one of the things that you're pointing to is sort of the need for the providers, the frontline folks, the supervisors, the agency leaders across the board, folks who are in charge of providing a response or service to young people, that there is a need for attention to identities and wellness among the people who are providing services to young people as well. That this activity that you did with folks in California was in reference to themselves, correct?
But can you repeat that? Sorry, I was.
No problem. Just lifting up that wellness and thinking about wellness and mental health supports and a reflection of identity is important to direct to providers, right? As a group themselves who are caring for and responding to youth who might be in crisis.
Yes, and I actually do this. So I do this with my trainees in my clinic, but I do this with my patients, Dr. Javdani. And when I bring it into the room, you should see their face when I say, today we're going to talk a little bit about you. I want to hear about how you identify yourself. What are some things that make you you? And they almost look at me like, are you serious? Like, I thought I was going to hear, I thought I was here for therapy. And I'm like, this is part of it, right? Who you are as a person impacts how you see the world, how you react to the world, how you cope with the things that you experience in the world. And I was just catching up on the chat, and a lot of people were bringing up that the main identity that they think about the most often is their ethnicity, their age, their religion. All of these things impact us. So when I bring it into the therapeutic space, it has opened so many things for me as a clinician to really connect with the patients, especially if they're adolescents. I really like a comment that Ismael put in the chat on how identity development is so crucial in adolescents. So their identity development is going to be impacted by their experiences that they have in the community at school, right? So how do we buffer how these experiences fragment their identity, as Ismael so beautifully put it in the chat. So I actually print this out and do it as part of session 1 before I do my safety planning, because then I integrate their identity development into the safety planning that I do with all.
Wonderful. And we have a question in the Q&A related to intervention response or response to young people in crisis. And the question is sort of, once we engage in some kind of an intervention at whatever level, what do you think the success rates are for these kinds of responses? And how do we know that the interventions we have implemented or done have worked or have been effective? What are some strategies to think about that? Yeah,
well, it all depends on your goal and what's the target that you are focusing on in your intervention. For adolescent suicide interventions in particular, to date, there's about 20 randomized controlled trials. Only 50% of those trials have been effective, meaning that they work. And those 50% of those trials, what signaled that they were effective is that they reduced the number of reattempts at the follow-up points, which was at the 12 follow-up points. And in one study, what I did is I analyzed all of the intervention manuals for every single intervention that worked. And what I did is I looked through every single manual and I looked at what were the common elements that all of these effective interventions had. And they all had 3 things, the ones that worked. A, they had a strong safety plan with lethal means restriction. 2, they had parent or caregiver involvement in one way or another. The 10 interventions that didn't work, they didn't include a parent or caregiver. And 3, they included skills training on how to address problem areas. So it was like a long list of skills training. So you need all of these 3 components if you want an intervention to work. One way that you can test in your own clinic if it works is if you do follow up, right, with your patients and you assess if the interventions that you're providing them, are they acceptable? If you ask your providers, was it feasible for you to actually implement this? And then for you to do your follow-up to see if it actually reduced whether it was ideation, whether it was non-suicidal self-injury, you do want to keep a record of how effective the strategies that you're doing are working. So in our clinic, what we do is we do what we call caring contacts. So whenever we have a family come into our clinic, we do the safety plan, we do the family intervention across 2 sessions. We tell them, we're going to call you, in about 3 months, and then again in 6 months, just to see how you're doing. And then they kind of already are expecting for us to call. And when we do our caring contact call, we ask them, how has the intervention been working for you? What do you think was the most effective component? More often than not, they say, you linking me to care in the community was really helpful, or you educating me on how to keep my kids safe by removing, sharp objects from the home was really effective. So I always try to integrate my research and my clinical, because they oftentimes inform each other.
Absolutely. Absolutely. And you mentioned, of the 3 kind of common elements of a responsive intervention, the first was a strong safety plan and restricting access to lethal means, or, things that people might use in order to potentially engage in harm with or without an intent to die. We have another question in the chat that's asking about the role of mentoring in the safety planning process, and how we think about mentoring as a part of it, an effective part of it or not.
Oh my God, I love whoever asked me this question. Please reach out to me so we can talk, because that's actually what we are developing in our lab. Is what we're finding, that although it's helpful to integrate a parent into your safety planning, sometimes parents are the problem that are leading to the kids to be in that state that they're in the first place. So what we're doing is we're having the youth nominate a person, sometimes an adult, sometimes is a same age peer. We ask them to nominate someone whom they feel that they are safe, and that they will pick up the phone if they call them during a state of crisis. And we have them nominate a mentor, someone that they genuinely feel that they're connected to. And there's actually evidence for this specific type of mentoring by, oh my God, Cheryl. If you look at Cheryl, she had an intervention called the Youth Nominated Support System. And what they found was that the youth that nominated a mentor to keep them safe as part of their safety planning, 14 years later, those kids that had a mentor had significantly reduced rates of suicide compared to the youth that didn't have a mentor that they nominated. So this is the only trial to date that has done such a long longitudinal follow-up. 14 years after they did this, they found that there was a strong effect with mentoring. So for suicide in particular, I think there is so much that we can do with same age mentoring, or just peer mentoring, as a way of building connectedness and protective processes.
Fantastic. And I'm gonna add that study to the chat so that folks who are interested can have access to it. So it sounds like, and thank you for addressing that. Sometimes parental involvement or familial involvement is just not an option. And it sounds like when we think about system impacted youth in particular, or youth who have some of the risk factors that you indicated, like having family who are incarcerated, for a variety of different reasons, familial involvement might not be ideal or even possible. And in those scenarios, it sounds like you're suggesting that going back to the young person and saying, who is a person who you might nominate to respond to you, for you to call if you're in a crisis, that's one really concrete strategy that can be used, especially when young people might be in a residential placement facility, might not have access to parents or caregivers. Yeah. And of course, building that model out, that those folks could be actual mentors, right? That have a somewhat sustained relationship with young people.
Yes. And educating those mentors, building their capacity on how to respond to crises. So in the beginning, when we had youth mentor like their coaches or mentor, you know, their boss at you know, that they had at Subway, those mentors were like, I'd be thrilled to do it, but I don't know, like, what do I do if he tells me he's having thoughts of suicide? Like, I don't feel that I'm equipped to do that. So then when we did a brief psychoeducation with those nominated mentors, well, this is how you respond. These are the resources that are there for you. 988 is not just for a person that's in crisis, but it's actually for a support person that needs support when they're helping somebody in crisis. Also educating them on the language, right? On how to not use stigmatizing language and how to encourage kids to seek out help when they're in distress, and really reinforcing for that kid reaching out to them, right? That's a plus. If you have someone reaching out to you because they're in distress, that's a great thing that they're reaching out for you, that they're looking for care. So building capacity among mentors is also another important strategy that we're focusing on.
Wonderful. And we have not a question, but a comment in the chat. You're a brilliant therapist. Definitely wanna raise that up, and lots of folks appreciating your thoughtful responses, Dr. Meza. We have a live question too, or from Orlando. Orlando, you are unmuted if you would like to ask your question. Or Orlando, perhaps you are muted.
I don't think they can unmute, maybe. Can they?
We're working on it. Let's see, Orlando, we're inviting you to unmute. I wonder if you're able to. Okay, so sorry about that, Orlando. It looks like on our end, it looks like it says talking permitted. So sorry if that's not working on your end, and please feel free to chat your question or just, you know, email us or Dr. Meza for your question. So sorry about that. I have, you know, to close, I think there have been a lot of kinds of, you know, questions or thoughts in the chat that underlie this idea that there are misperceptions around suicide among young people, and especially around Black and Brown young people, and especially around system impacted young people, right? And so if you could perhaps just tell us a little bit about some of the most common myths around suicide with young people that you believe are still pervasive and that we can try to attend to. Some of the, maybe the top 2 or 3 myths about suicide among young people and system impacted young people in particular for us to keep in mind.
Okay. I would say at the top of the list is this idea or this myth that asking about suicide is going to increase someone's, that we're going to somehow cause inception, that they're automatically going to start thinking about suicide if you screen for suicide, if you ask for suicide. So many researchers and clinicians have asked me this question, and what the literature suggests is actually it has the opposite effect. There's something therapeutic about you asking someone if they are having thoughts of harming themselves or of ending their life, because it validates their experience, right? It validates the fact that you see it and that you want to ask and check in on them. So I would say that's myth number 1. That is the one that bugs me the most. And then number 2, I primarily hear it from parents, is this idea that youth engage in self-harm as a way to get attention, that it's like attention seeking. And another reason why I really dislike the term suicide gesture or suicidal gesture, because it really invalidates the distress that they're feeling in order to engage in that behavior. So I spend a lot of time with parents talking about how the intent is not up to us to put an intent on their behavior. We have to focus on the thing that we're seeing, the behavior, right? The behavior is that they're cutting themselves. if they're impulsive or if there are things that impact their impulsivity, like drugs, if those are involved, those cuts are going to be more severe. And we want to make sure that we're addressing them in a way that is going to prevent it. So I always talk to parents about, it's not about the intention that you think as a perceiver, it's about the behaviors that we're observing. And let's remove this idea of they're doing it to get attention, right? So I would say those are my top two that I think are big myths that I want to dismantle and focus on.
Thank you so much, Dr. Mesa, and I am delighted to close this webinar. And attendees, please look out for flyers and information for the third in the series of webinars coming up. You should all have access to Dr. Mesa's email address, and you will have access to the slides presented today. The survey link has also been posted in the chat. If you haven't taken the survey, we would really appreciate if you did so. And thank you so much for coming. Thank you again, Dr. Mesa, for your thoughtful presentation, and have a lovely day.
Thank you, everyone. We hope to see you in webinar 4, where we are going to talk about how do we integrate these social cultural risk and protective factors into our treatment. So we are actually going to give you tools on how to integrate it into your treatment. Thank you, everyone.